want to welcome everybody, and we're so excited. We have a large number of attendees to today's presentation. So today's topic, supporting sepsis, from diagnosis to claim denials. And I want to introduce Christy Pollard, and I've worked with Christy for years, and her and I just really love doing the webinars together, I think, and she gets a kick out of me trying to say some talk anatomy stuff that I cannot pronounce very well. So we'll see how today's presentation goes. But Christy is a senior consultant, and she has more than 20 years of industry experience. She is our lead developer for our web-based and our instructor-led training materials. She also does a lot of the instructor-led training. She does training in ICD-10-CM, PCS, and CPT, as well as she performs some of the DRG and APC audits. Christy's a Colorado native who has never skied. In her spare time, she partakes in outdoors activities, and this is her words, that do not involve strapping two boards to her feet and barreling down a slippery slope. Christy enjoys mentoring new coders and particularly enjoys spending time with her family. So at this time, Christy, I'm going to turn it over to you and let you kick us off.
Thank you, Kathy, and thank you everybody for joining us today on this presentation. Today's agenda is, first of all, I would say that if you happened to attend the sepsis webinar that we did a couple years ago, I think it was towards the end of 2017, when I first decided to do this topic again, I was just going to kind of update that presentation, and it ended up being a completely new presentation. There's been so much published on sepsis over the last year and a half, a couple of tweaked guidelines and a lot of new things. So I will say that this is a coding webinar, but sepsis isn't really a coding issue. And I mean, it's a coding issue in as much that payment is based on codes for hospitals, but it also introduces the issue of clinical validation, which is not a coding function. I will say that I'm not going to answer all your questions today because I still have questions, and I think everybody has questions. Hopefully we will address some of the areas where you have concerns, and maybe you can even help educate me a little bit with some of the polling questions that we have for today. So today, if you've never attended one of our webinars before, welcome to our fun little cartoon animals. It's usually an animal. Today we happen to have Tiny Tim, a smiling face, to go through a difficult topic where we are going to compare and contrast the Sepsis 2 and Sepsis 3 criteria. We're going to review the sepsis coding guidelines and present strategies for addressing the sepsis clinical denials. Now, one note before I do move on, we did market today's webinar for both the facility coding coders as well as for Profi, because we do realize that Profi coders are coding for hospital inpatient services for their docs. And these guidelines, many of the guidelines apply to them as well. And I think that by including our Profi coders who maybe have a closer line to the physicians, they can help educate physicians on some of the documentation issues that we do face in coding and validating sepsis. So I'm not going to go through every single sepsis coding guideline, but I'm going to touch on a couple. I really want to talk about some of the bigger issues that we have seen through our coding audits over the last couple of years, as well as things that we've seen in literature, lots of articles and lots of buzz throughout the industry on what's going on. And I think one of the best quotes I ever heard about sepsis came from Dr. John Alion, who is the founder and CEO of Chartwise Medical Systems, and he does a lot with clinical documentation improvement. And it made me laugh, but you know, I think it's kind of true. He said sepsis is like pornography. I can't deny it, or define it, but I know it when I see it. So sepsis, in trying to sit down and say, okay, this is sepsis, it's not one of those things where it can really be specifically defined. So it is not a specific illness. And what they are starting to learn about sepsis is that it's a syndrome identified by a group of clinical signs and symptoms in a patient with a suspected infection. And unfortunately, there's not this one test that we can administer and say, yes, the patient has sepsis. As we know, people who have sepsis don't always have positive blood cultures, so we can't use that as an indication. But unfortunately, it is the primary cause of death from infection, and it is a huge issue for clinicians. It is something that they need to identify immediately and treat immediately in order to improve patient outcomes. So when we talk about the coding of sepsis, you know, we're a lot of times really focused on DRGs and reimbursement and all this other stuff, but if you think of it more from the clinician's point of view, the doctor is trying to identify if this patient has sepsis and treat them, begin the treatment immediately so that the patient won't die. You may have heard a lot of buzz about sepsis 2 versus sepsis 3 criteria and definitions. And before I get into the difference between these two, I will say that these are clinical definitions that are used by clinicians. These are not definitions that we as coders use to say the patient has sepsis. So our determination on whether or not a patient has sepsis is the doctor wrote it down. And hopefully, but I think that if you kind of stick your head in the sand and say, I'm only going to code what the doctor tells me, and you don't understand the clinical criteria that lie behind this, then you're not likely to identify or understand clinical denials when they come in. So just for clarification, in my old presentation, I had a slide about sepsis 1, which is something that got tweaked several years ago. I think it was 99 or 2000 that it got tweaked, and it became the sepsis 2 definition that we were familiar with so long. And the sepsis 2 definition was a systemic inflammatory response to infection that had 2 or more of the criteria that are shown here. So the high temperature, actually high or low temperature, tachycardia, so high heart rate, increased respiratory rate, or high white count. So those were kind of the 4 things that we were looking at. And then sepsis, severe sepsis was looked at as a progression of this systemic inflammatory response where the patient's organs started to shut down. So it was sepsis complicated by an acute organ dysfunction. And then they also defined septic shock, which is a further progression of severe sepsis, where then they have sepsis-induced hypotension that does not respond to adequate fluid resuscitation. At the beginning of I think it was like April 2017, there was there were 2 medical societies that came together to really look at the sepsis criteria and say, you know, is this criteria effective? Is it really saving lives? And out of that, they came up with a new definition of sepsis. That's the sepsis 3 definition that we all are hearing about right now. So they are now saying that sepsis is a life-threatening organ dysfunction caused by a dysregulated host response to infection. What does that mean? As a coder, what it means, or as a non-clinician, it means that the patient has an infection that is so severe that the body is reacting to that by shutting down organs. Now, if you think that that sounds like severe sepsis, you're right. So now they're saying that sepsis, according to sepsis 3 criteria, severe sepsis is sepsis. There is no such thing as severe sepsis. The sepsis 3 criteria is validated or diagnosed according to a tool called the sequential organ Failure Assessment Score, or SOFA score. And it's complicated. So I wanted to include that information for you, but it goes into a lot of detail. All you really need to know is that's what doctors are supposed to be using to figure out if the patient has sepsis according to the Sepsis 3 criteria. It looks at lab values, it looks at lots of different tests, it looks at the patient's condition. Now, it's great. It can be great, it can be effective, and I will say that not all physicians agree with the Sepsis 3 criteria, so it's not even, really clear what we should be doing. The problem with the SOFA score is if the patient is critically ill, you may not have time to get all of those tests and everything before saying, yeah, we need to start treatment, and that can delay treatment, which then can lead to poor patient outcomes. So they've developed a condensed version of that called the Quick SOFA, or the Q SOFA score, that can be done without all the tests, and it can be done quickly, and they can immediately start to administer treatment. Now, on the Sepsis 3 criteria, there is no definition of severe sepsis because it's considered to be a redundant term. And septic shock then is sepsis with persisting hypotension requiring vasopressors to maintain the patient's blood pressure, and also talks about serum lactate levels over 2 despite adequate volume resuscitation. So I go through this slide and I present these side by side so that you know what physicians and CDI professionals are talking about when they talk about Sepsis 2 versus Sepsis 3 criteria. As a coder, though, we code sepsis when the doctor says sepsis. So let's talk about a couple of reporting facts when it comes to reporting, and I use the term reporting because it goes beyond coding, but reporting sepsis and septic shock and all these other things. So our ICD-10 codes are based on Sepsis 2 criteria. And at this time, to date, I have not seen anything come through the Coordination and Maintenance Committee that would suggest that they are going to change the coding system and update it to Sepsis 3 criteria. So it is a fact that we have a separate code for severe sepsis because our codes are based off of Sepsis 2 criteria. We also know that we cannot code from clinical criteria. We have a coding guideline that says that we as coders are expected to code what the physician documents, and we cannot apply clinical criteria to say, oh yes, the patient has sepsis because of X, Y, and Z. That's not our job. That's not what we've been trained for. So to us, provider documentation of sepsis is coded as sepsis. And provider documentation linking sepsis to organ dysfunction is coded as severe sepsis. Now, in addition to that, I mentioned that the reporting goes beyond ICD-10 codes. There is a core measure through CMS that is based on Sepsis 2 criteria, and that gets reported by through the core measures inventory tool that is usually completed by a nurse. And that is also based on Sepsis 2 criteria. There's a lot of argument out there from Medicare saying, we don't really buy into the Sepsis 3 criteria. But the problem is that we have some payers who are denying claims, saying that it didn't meet criteria, and they are starting to use Sepsis 3 in their definitions. So United Healthcare announced towards the end of last year that beginning January 1st of this year, they would be using Sepsis 3 criteria to review all the sepsis claims. So you may be starting to see denials from United Healthcare saying that the patient didn't really have sepsis, and that's what you coded because that's what the doctor said, but they may be using Sepsis 3 criteria. So how do we operate in an environment where our codes are based off of old criteria? We have payers who are reviewing claims based off of new criteria that some physicians in the industry don't think is the right criteria. And how do we manage all this? I will say I just came across an article that was just released yesterday from RAC Monitor, breaking news article that said that the Healthcare Association of New York announced on Tuesday, so today's Thursday, they announced on Tuesday that they will not use United Healthcare Sepsis 3 criteria when reviewing claims to validate sepsis for payment. So if you are in the state of New York, they are saying that New York does not recognize Sepsis 3 criteria. They use Sepsis 2 criteria, and that they won't use Sepsis 3 criteria at all in the state of New York. The question I have is, who's going to follow suit? Are we going to see other state hospital associations weigh in and say, you know what, enough is enough? We're going to base everything off of Sepsis 2. Stay tuned. I imagine that my presentation will be outdated 5 minutes after I complete it, or maybe even 5 minutes before I complete it. I wanted to include a little bit of information here on the sepsis CMS core measure, and let me preface this by saying that I am not a core measures expert by any stretch of the imagination. But in researching some of the coding issues that I've seen on auditing regarding sepsis, I had to dig into the core measures a little bit. So again, this is data that gets abstracted by the core measures team and reported through the core measures inventory tool. This is not reported through codes. And it just kind of shows you what they're focusing on. They are, from what I understand, the core measures are really strict. It's very hard to meet all of the elements. So they've got all these things that have to happen. They have to have measurement of lactate levels. They have to get blood cultures. They have to give broad spectrum antibiotics, fluid resuscitation, vasopressor administration, reassessment of volume status and tissue perfusion, and a repeat lactate measurement. And all this stuff has to happen within a certain time frame. And it's incredibly difficult to meet this core measure based off of the time requirements alone. But again, this is also going to be based off of Sepsis 2 criteria. So that kind of leaves us in limbo. Just to summarize what I've been talking about for the last 10, 15 minutes, you know, we've got coding versus core measures. We've got payer policies. We've got Sepsis 2 criteria, Sepsis 3 criteria out there. We got facility policy, and then let's add state policy in here too, because we now have the state of New York saying that we are not going to recognize Sepsis 3 criteria. So questions to you: are your clinicians applying Sepsis 3 criteria? And if they are, do you, if depending on what they're using, do you have a policy stating which criteria your clinicians use? And how do you apply Sepsis 3 documentation to Sepsis 3 codes or to Sepsis 2 codes? Are your core measure nurses involved in any of the clinical validation? And are you getting clinical denials? These are questions that somebody in your organization should know the answer to, because it's going to determine how you're going to move forward. And to help me better understand what you guys are doing, we are going to do our first polling question. So Kathy, would you launch the poll, please?
Sure thing. So this is how we can interact with you as our audience. So this is what Christy's been talking about and wants to know from you. So, and there's no right or wrong answer here, but it's just a kind of, let's see where our polling audience is. So are your physicians using Sepsis 3 criteria to diagnose sepsis? And your choices are yes, and we do have a policy, or yes, but we don't have a policy, or no, they're not using Sepsis 3 criteria, or you don't know. So to the best of your knowledge, are your physicians using Sepsis 3 criteria to diagnose sepsis? And your choice is yes, and we have a policy, yes, but we don't have a policy, nope, and I don't know. And I would encourage you, if you're in a group full of people, is what's the general consensus? Because it might even differ, especially if you are uncertain, or yeah, we know that they are using Sepsis 3, but I don't know if we have a policy. So anybody else want to weigh in on this? And the nice thing about the polling questions is then you can kind of see where the responses are and where is, what's the percentage of our audience is saying. So I'm going to go ahead and close the poll. I've got about, 2/3 of you who have voted. Anybody else want to weigh in? I'm going to close the poll. 3, 2, 1. Okay, Christy and our polling audience, we've got kind of answers all over the place. We do have 3%, so a very small percentage is saying, yep, our physicians are using sepsis 3 criteria and we have a policy. We have 32% are saying, nope, they are not using sepsis 3 criteria. And the majority at 65% does not know.
Okay. So this one, I had asked this question in my last webinar about 1.5 years ago, and really had only given the options of yes, no, and I don't know. And I wanted to break out the yeses because if you said yes and you have a policy, and that policy is in writing at your hospital, then that could potentially save you in an audit if you should ever get audited. A large percent of you say, no, we're not using the Sepsis 3 criteria. I would encourage those of you who said no within your facilities to get that policy in writing as well, because especially with United Healthcare and potentially some other payers following suit, you may see that you're getting denials. Here's the thing, under Sepsis 3 criteria, it's really looking like more money going back to the insurance company. So it's definitely worth it to them to go after these cases. And then several of you said you don't know, and that really does not surprise me because I think we're all kind of in a state of flux right now. Okay, thank you, Kathy. Let's move on and talk about a couple of coding guidelines. So if I completely overwhelmed you with that first piece, I'm sorry, that wasn't my intention. I can't do a sepsis presentation without telling you what the issues are out there, because you can code according to all the coding guidelines and still get a denial. And it's so frustrating as a coder. And they'll call it, a lot of times they'll call it a coding denial, or they'll call it a clinical denial, but they'll tell you to change the codes. And that's uncomfortable for us as coders because we're taught to code what the doctor is documenting. So looking at the coding guidelines, and I will say that I've started using this OCG acronym on my slides because it saves priceless space on an already wordy slide. It's just official coding guidelines. So you will see the OCG along with the guideline number listed and on several of these slides, and I've just given you some highlights since you can all read the official coding guidelines. But the basic guidelines say that when you're coding sepsis, you code first the underlying systemic infection, which I think is kind of confusing. That's the Sepsis Code. So the default code for sepsis, if there is no organism documented, is A41.9. And then they also tell us that a code from severe sepsis should not be assigned unless severe sepsis or an associated organ dysfunction is documented. Now, according to Sepsis 3 criteria, anytime the doctor says sepsis, it should be this R65.2 code, but you got to be careful. I would not do that unless you have an official policy with your hospital. You want to make sure that you're only assigning this code R65.2 when the physician either documents severe sepsis or he says sepsis and links it with an acute organ dysfunction. So let's look at that acute organ dysfunction a little more closely with sepsis. Many of you are probably aware of the with coding convention. We do have a coding guideline. It's actually a convention in the section of the convention section of the coding guidelines that says that conditions linked using with should be coded as related, but then there's an important addition there that says unless another guideline exists that specifically requires a documented linkage between two conditions. And for severe sepsis to be coded, we must have that documented link between the sepsis and the acute organ dysfunction. So what we don't want to do not assume that acute organ dysfunction is related to sepsis. There could be a lot going on with this patient, and they could have an acute organ dysfunction that is caused by something else. Do not code severe sepsis if there is not a link clearly documented between the sepsis and the acute organ dysfunction. So just the two being documented is enough. We really need the doctor to say. And do not code severe sepsis if acute organ dysfunction is related to a medical condition other than sepsis. So again, we've got to be super careful, especially in our current inpatient setting. You know, we've got patients who are really sick. That's why they get admitted. We don't just admit people willy-nilly. Patients who are admitted usually have multiple comorbidities, lots of different things going on, and you have to look at the entire clinical picture. And you can't really narrow down sepsis to an A plus B plus C equals sepsis, because their comorbidities and the other conditions and things that are going on really do impact that. There is another CDI physician who's written a lot of articles for ICD-10 Monitor, Dr. Cesar Lamoco, and he's actually trademarked the term the clinical truth, and that's what he's always talking about is, you know, you can't get it down to just a set of criteria and ignore what else is going on with that patient. So I know I'm just so passionate on this subject. Coding severe sepsis. So a couple of official coding guidelines that I have combined and just pulled out important points for this slide. When you do have that documented link between the organ dysfunction and sepsis, or the doctor has said severe sepsis, then it requires at least two codes. That first code is always going to be the underlying systemic infection. And the second code is going to be the severe sepsis code. R65.20 is never listed first. It's always an additional code. And if you look under the notes in the tabular list for code R65.2, it is going to tell you that it can't be assigned first. R65.20 is without septic shock. R65.21 is with septic shock. Then you add additional codes for that acute organ dysfunction, whether it be acute renal failure or acute respiratory failure or something else. And then just remember that septic shock, by definition, is sepsis with acute organ dysfunction. So that is like the only time where he doesn't actually have to say severe sepsis to code it, because septic shock is severe sepsis. It's a very severe form of severe sepsis. It's the severest form of severe sepsis. Is this confusing? Yeah, it's confusing. So a couple of reminders, and I put this out there because I see people making this mistake a lot, that the R65.2 codes cannot be standalone codes, and they cannot be first listed. You have to have that underlying infection code sequenced first. I can always tell when people are coding from the index and not reading the tabular list because they're sequencing these incorrectly or forgetting the sepsis code altogether. A little more about sepsis and organ dysfunction, because this is something that has caused actually a lot of discussion among my coworkers, which is, what is organ dysfunction? I mean, how do I know that what the doctor has documented, okay, he says that this is due to sepsis, but is it organ dysfunction? Well, a couple of things make it a little bit easier. There is this use additional code to identify specific acute organ dysfunction note under our severe sepsis code. And it lists several conditions like acute kidney failure, acute respiratory failure, etc. And Coding Clinic came out with a good article a couple years ago, and they said that, there is a list in the tabular, as is shown here, but it's not exhaustive. But if you are not sure, if you don't know if that condition that's been linked to sepsis is considered to be an acute organ dysfunction, then you query. And let me just say that as a coder, you're not required to know that. You're not a clinical person. You're not required to know that. If you have a CDI nurse who's telling you to add something because it's acute organ dysfunction and you're still not sure, then it's okay to go back to the physician and send a query. And one of the biggest ones that we have been seeing that's been linked as an acute organ dysfunction is lactic acidosis. And this is one that I have done some digging on, and we internally at Haugen Consulting Group have come up with a best practice for this. So let's just talk about what it is. Lactic acidosis is an overproduction or underutilization of lactic acid, and it has several different causes. You might think of, a really big workout where you completely overwork your muscles and your muscles build up this lactic acid, and it's just kind of there. It can also, though, be caused by hypovolemia, cardiac failure. It can be caused by sepsis. It can be a symptom of something like respiratory failure. It can be a symptom of chronic kidney failure. There are so many potential causes of lactic acidosis. So there is a normal reference range for lactic acid that I included here, and I Googled that so you could kind of see what it is, because remember, some of those sepsis criteria and some of the core measure stuff focus on the values for lactic acid. So high lactate levels may present with or without lactic acidosis. So just because you have this buildup of lactic acid and have these high lactate levels does not mean that you have lactic acidosis. So the question becomes, if the patient has sepsis and the physician documents lactic acidosis, is that an acute organ dysfunction? And our best practice recommendation is that you query the physician, because there are so many potential other causes of lactic acidosis. So remember when I said that, you can't look at certain symptoms and lab values in a bubble. You've got to look at, to quote Dr. Lamoco, the patient's clinical truth and everything that's going on with that patient. If I have a patient who has sepsis, lactic acidosis, and chronic renal failure, the lactic acidosis could be due to the sepsis, but it could also be due to the chronic renal failure. Chronic renal failure is not an acute organ dysfunction. So a patient with chronic renal failure and sepsis, that's not severe sepsis. So that is where you need to go back to the doctor and say, hey, can you tell me, do you think that this patient has severe sepsis with lactic acidosis, or is that lactic acidosis related to something else? So I have my little turtle here, says it's a controversial subject, and I'm sorry that all he does is smile. And I thought, oh, he's a nice, cheerful turtle. But then I realized that he never looks frowny, and a lot of times I look frowny when I'm talking about this subject because it's so controversial. This is an area where when you're talking to core measures nurses or to CDI staff, that they might be trying to push clinical stuff on you when we really need to back up and say, you know what, I need definitive documentation from the doctor saying that these two conditions are interrelated. And that's going to bring us to the next polling question. Kathy, I think we could do this one kind of quick.
Okay. So just what Christy mentioned. True or false? What do you think? Patients with lactic acidosis and sepsis have severe sepsis. Is that true, false, or it's really kind of a complicated topic? So true or false? Patients with lactic acidosis and sepsis have severe sepsis. Is that true, false, or hey, really, this is complicated? So what do you think? Responses are coming in. Got about 50% of you who have voted. Anybody else want to weigh in? Numbers are still tumbling in. Anybody else want to weigh in? I'm going to close the poll here. 3, 2, 1. Responses. Okay, the majority. Woohoo! 67% are saying, yep, this is a complicated topic. I do have 30% of the audience is saying this is a false statement, and I've just got a slight minority at 3% is saying it is true.
All right, Kathy. Well, it could be true. It could be false. But the answer is it's complicated because it really depends on that individual patient and what is going on with that patient clinically and the other complications and comorbidities that exist along with the sepsis and the lactic acidosis. So I would say for this one, use extreme caution. And you are likely, again, to get pushback from CDI staff because nurses are clinical. But remember, it is okay if it's not really clear and we have that coding clinic to back us up and say we can go query the physician. All right, thank you, Kathy. So moving on to a couple of other guidelines, the coding guidelines for post-procedural sepsis and septic shock were updated on October 1st, and I wanted to talk about this because there are a couple of new codes that went into effect on October 1st. And there's a coding clinic that's a little bit concerning. So post-procedural sepsis and septic shock, first of all, first and foremost, the doctor must make a connection and document a link between the procedure and the sepsis. We're not even talking about using these codes unless that documented link exists. And the coding guidelines are kind of split. They've got a section for post-procedural sepsis codes and sequencing, and then post-procedural septic shock codes and sequencing. Some of the new codes that they came up with, so we have these new codes for post-procedural infection, and it's of the wound, and it has to do with depth. So they've got the post-procedural codes, but then they also have obstetric post-procedural codes. So, you know, infections potentially due to like a C-section or maybe a laceration repair. So the sequencing is that first you assign this code for the depth of the infection. So, you know, it's like superficial and deep and I'm going based off of memory here. And then there's a code that goes after that specifically for sepsis following a procedure. Now the difference between the T8144 and the O8604 is, you know, non-pregnant patient, and then procedure or complication sepsis due to an OB procedure. After that, you code the underlying infectious agent, which would be a B code, you know, an infection and other conditions classified elsewhere. And if the patient has severe sepsis, you can add that code and then any additional codes for acute organ dysfunction if applicable. The septic shock, a little similar, except with the exception of we're adding in a code for post-procedural septic shock, and they are specifically telling us not to assign R65.21. So there is a specific code for post-procedural septic shock. When you have the septic shock due to a procedure, you are not going to use the R65.21. So there is a coding clinic that came out just in, oh wait, let me do this guideline first, because this is leading up to a discrepancy between the guidelines and coding clinic. So we just talked about the the guidelines for obstetrical wounds, sepsis due to obstetrical wounds, there is also code 085 for puerperal sepsis, puerperal meaning postpartum sepsis. And there is a coding guideline for this, and they tell you how to use this code and how to sequence it. So the first code in a patient with postpartum sepsis is 085, followed by a B code for the organism. They specifically say not to use the A40 and A41 codes, but you can add codes for severe sepsis and associated organ dysfunction if present. Now, if you're wondering what the postpartum period is, it is defined in the official coding guidelines in Tim's little bubble here as beginning immediately after delivery and continuing for 6 weeks following delivery. In Coding Clinic, fourth quarter 2018, so the one that just came out a few months ago, they gave an example of a woman who came in with fever and induration of the cesarean incision site. They worked her up, they did all these blood cultures, and then the final diagnosis was GBS sepsis due to deep incisional infection of cesarean wound. Now, following the official coding guidelines, this should be coded with to determine or indicate the infection of the site. So this is 086.02, infection of obstetrical surgical wound, deep incisional site. So that follows the coding guidelines. But then Coding Clinic says to add a code for puerperal sepsis, which does not follow the coding guideline. Coding guideline says that you should add code 086.04 for sepsis due to an obstetrical procedure, and then add the B95.1. So I wanted to point out that there is a conflict here between the official coding guidelines and Coding Clinic, and I did submit a letter to Coding Clinic this week to see if we could get clarification on this. I'm thinking that it was incorrect in Coding Clinic, and really the code should be the 085 should have been an 086.04 instead. Another piece of the guideline, under the post-procedural sepsis guideline, there's a whole new section about sepsis due to infusion, transfusion, or therapeutic injection or immunization, and they list out the sequencing there as well. I don't know about you. I find the coding guidelines incredibly convoluted, so I like to step it out like this. You can use my slides as your cheat sheet, if you will, but it matches up with what they say in the guidelines. I just think it looks better, personally. They did have an example of this in Coding Clinic fourth quarter, and this one we reviewed closely. We didn't have an issue with the advice that they gave here, so this one looks pretty good. Do want to talk a little bit about sepsis with non-infectious conditions. There is a coding guideline that talks about sepsis that is related to non-infectious conditions. So thinking kind of along the lines of a patient maybe who had severe burns and they ended up developing infection and then developing sepsis. So they give your sequencing guidelines there. So you sequence according to the circumstances of admission. If you had a patient who was burned and they came in for the burn and they developed sepsis after admission, then the burn would be sequenced first. But remember that most times sepsis is going to be sequenced first if it was present on admission. Even if, let's say the patient comes in with pneumonia and they have sepsis, if they're both present on admission, the sepsis is always first. There is a coding guideline for that. One of the things that I will throw out on this, and one of my colleagues recently was chatting with a group of coders, and they said that they are getting denials on sepsis due to conditions like appendicitis and peritonitis, and the payer is saying that those are inflammations and not infections. And so just be really, really careful, because the coding guidelines change If you have a patient who develops sepsis from a non-infectious condition and the sepsis wasn't present on admission, you are going to put your non-infectious condition first. But you may have let's say you do have a patient who came in with appendicitis and they developed sepsis. There are payers who are taking off that sepsis code and saying you can't code sepsis with appendicitis because appendicitis is not an infection, it's an inflammation. Now, I think that most times appendicitis really is an infection, but that's where you're going to have to get clinical staff involved to help fight some of these denials. And some of these are really nuisance denials that, I feel like they just don't want us to fight them, and they just figure we're not going to fight them and they'll be able to recoup money. Okay, next polling question. Kathy?
Okay, here's our question. In which scenario is a code from R65.2 for severe sepsis not assigned? Is it post-procedural severe sepsis, or post-procedural septic shock, or septic shock due to sepsis caused by a burn? In which scenario is a code from R65.2 for severe sepsis not assigned? And your choices are post-procedural severe sepsis, post-procedural septic shock, or septic shock due to sepsis caused by a burn. And I've got responses all over the place, and they're slowly trickling in, Christy. So I think you are going to have some great discussion on this one. So
it's really hard to say sepsis and septic shock that many times, isn't it?
I know. I was thinking it was a tongue twister. So anybody else want to weigh in before I close the poll and share, and then we'll let Christy discuss this. I'm going to close it in 3, 2, 1. Okay, Christy, like I said, we've got answers all over the board. We have the slight majority at 52% is saying it's post-procedural septic shock. Then we're tied at 24% evenly between post-procedural severe sepsis and septic shock due to sepsis caused by a burn.
Okay. Well, and I know I kind of glossed over the septic shock with caused by a burn, but if you were paying attention, I did say more than once that it is the second one. It's the post-procedural septic shock. We do not assign an R65.21 because there is a code T81.12 that says post-procedural septic shock, and you really don't need the R65 code with that because the T code says it all. All right, thank you, Kathy. So a couple of audit targets, because I don't think that the issue when it comes to coding or to sepsis is really that we don't know what to do as coders. I really don't think that's it. I think we're doing the best job that we can, but our hands are kind of tied. So there are a couple of audit targets. Sequencing sepsis and localized infection, when both are present on admission, again, sepsis is always the principal diagnosis, but be careful of those conditions that the payer may say, oh, this isn't an infection, it's an inflammation. There may be, when my coworker told me about this, I'm like, well, what if there's an abscess? I mean, isn't that infection? I mean, if you've got appendicitis with an abscess, isn't that infection? I feel like this is a nuisance denial, and I feel like they're just hoping you won't fight it so they can recoup the money. Also, there are a couple things, coding sepsis when clinical indicators are not met. And some of that is the United Healthcare saying we're going to use sepsis 3 criteria. You're going to be up against that if you have United Healthcare as one of your payers. But also, sepsis with lengths of stay less than 72 hours. That really goes back to that quote that I had at the beginning where Dr. Alien said, I can't define it, but I know it when I see it. And I could tell you that patients who have quote, sepsis and recover within 72 hours don't have sepsis, because we're talking about a condition that makes them critically ill, and they are in danger of dying if we don't get treatment going immediately. So this is one that they've been looking at, and it's easy to do a data dive on that one. You know, sepsis is principal diagnosis with a length of stay less than 72 hours. We recently saw one where it was an observation case, less than 72 hours denied. You know, they're not going to discharge the patient within 24 hours if they are critically ill with sepsis. So when do you have the green light, and when should you proceed with caution? And I'm not suggesting that coders be reviewing clinical criteria, but I'm kind of telling you of what is going to set you up for a potential denial. You know, we've in the green over here, we've got sepsis documented with clinical criteria. That's beautiful. That's amazing. That's what everybody wants. That's not what we always get. These you shouldn't be getting denials on. You probably have some where sepsis is documented, but the clinical criteria isn't backed up in the chart. And then the question becomes, which clinical criteria are we using, sepsis 2 or sepsis 3? This is not a coding function. This is where you got to get clinical staff involved. And then clinical criteria present without a documentation of sepsis. Those are the kinds of things that should be caught by CDI nurses, because they're able to then go back to the physician and say, hey, did you notice that, you know, the patient had X, Y, and Z? This meets the criteria that we use for sepsis. Do you want to document that? So it is very much a team approach. Coding sepsis is not all on the coder. And whether that frustrates you or, you know, kind of releases a little pressure, the fact of the matter is that we cannot code and validate sepsis alone. We're going to need everybody to work as a team. So the role, you know, everybody's role, we've got physicians who are documenting, we've got CDI who's validating, and CDI is kind of running the interference between the physicians and the coders who are assigning the final codes. So what is everybody's role? And this is the key takeaway for physicians. And if you work with physicians at all on their documentation, we want them to thoroughly document their thought process. And that is what is helping in fighting some of these denials and getting them appealed. If the doctor can thoroughly document his thought process, it's like going back to elementary school math class, show your work. You say the patient has sepsis, tell us why you think the patient has sepsis. So he needs to thoroughly document his thought process, but he also has to write that word, sepsis, somewhere in the chart. He also needs to document any acute organ dysfunction when it's present, and he needs to link it to the sepsis or to another condition if it's due to something else. So yeah, this is frustrating for a doctor. What does the doctor care about? Saving the patient's life. And I think that that's a really important thing for him to care about. But this is what we need in order to make sure that we're reporting and getting paid appropriately. So CDI is helping to determine which sepsis criteria are being used, and again, kind of running that interference between coding and the doctor, and discussing those ambiguous cases with providers to strengthen the documentation to make sure that he's showing his work. Now, as coders, what are our responsibilities? Our responsibilities are to code sepsis when it's documented. We shouldn't be looking at clinical criteria. We should just be saying, oh, look, he wrote down sepsis and coding it that way. We should be looking for acute organ dysfunction and what it's caused by. And if the doctor did his job and showed his work, then it's there in the documentation. And then we should be querying the provider if for some reason it didn't get caught by CDI, or if he didn't show all of his work, just to make sure that we have good, solid, strong documentation. And I'm going to skip this polling question, Kathy, because I've got just a couple more things that I think are more important than this. But you know, there are a couple of different ways for you to address conflicts between provider documentation and clinical criteria. You know, I think a lot of us say, oh, we code what the doctor says and that's what we do. Some people may say we code according to clinical criteria because we have a guideline, an internal guideline. Some say we give it to CDI. It's not our problem as coders. Maybe that you have something else that we haven't thought of, and maybe you just don't know. I would say, again, that the answer lies kind of somewhere between all of these. As a coder, we can't really code specifically according to clinical criteria, but we can work with CDI to help strengthen the physician's documentation so that we can code what the provider has documented. So a couple of tips for success. Don't forget, or for coding sepsis, sepsis, success, what's the difference? When a patient's admitted for sepsis due to a localized infection, again, your sepsis is always sequenced first. That's in the coding guidelines. Sepsis caused by a procedure or an infusion, transfusion, injection gets a complication code. And don't forget that we've got the O codes for those that are due to obstetrical procedures. We also code according to provider documentation, not clinical criteria. That's what all of the guidelines tell us. But absolutely get your CDI team involved and be ready to address insurers and auditors who are looking at clinical criteria, because you can code according to what the doctor says until you're blue in the face, and they can still come back and tell you you coded it wrong when you coded it according to what the doctor said. It's just that the insurance company doesn't like his clinical criteria. Also recommend developing a sepsis documentation task force, and I think this is going to become a bigger deal moving forward. Your goals being to provide a unified approach to documenting, coding, billing, and reporting sepsis conditions. Ensure that your requirements are met for coding and core measures reporting, and reduce the number of sepsis claim denials. And we even tell you who you should get involved in that. I have business office on here. Here's a new one. Focus on process improvement, and I'm going to fast forward all the way to the very bottom because some facilities are starting to do this. They're including sepsis coding verbiage in their contracts with payers. They're saying, you know what, we're going to head it off at the pass. If, this particular payer says they're going to use the sepsis 3 criteria, we're going to write it into the policy, into the contract that says that we don't use sepsis 3 criteria here, we use sepsis 2. Or, something different. It is really hard for them to say no to you if you throw their contract back in their face. So, this is so much bigger than the coder. This is not something that we can determine on our own. So a couple things that we can assist with: evaluate the query process. Are your queries effective? Are you only querying to increase the DRG? Because you should be querying to strengthen documentation. It shouldn't just be about money. You might want to look at pre-bill peer reviews of claims with sepsis codes to make sure that you're not missing something. And then track those denials and look at core measures data within your hospital and see how everything lines up. So as a quick summary, our sepsis definitions are evolving. Not everybody's on the same page. And because of the core measures, it's not just about reimbursement. Coding and reporting sepsis isn't just the coder's responsibility. So if you as a coder feel like it's all on your shoulders, it's not. And because the current clinical definitions don't match what we have for our code structure, it's going to create the mess that we have right now. So I hope that answered a couple of your questions. I used a ton of references for this presentation, and I've listed out the most important ones here if you want to go back and read some of those. And I know that I am at time and we don't have time for live questions, but here's my email address. You can shoot me an email and I will be sure to get you a response, even if it's I don't know. And that's going to do it for me today. Kathy, do you have anything to wrap up?
I sure do. Thank you, first of all, Christy, for a wonderful presentation. And I noticed that we did not have any questions come through the chat window, but as Christy mentioned, go ahead and if you have something that you've thought about right now, email Christy, because what we will do is we will put together an FAQ video now on our YouTube channel and answer some of those questions. So we want to thank you for your time and your attention today. Please take a couple minutes to fill out the survey that will pop up as you exit from here. Let us know what you thought, and then check us out, and we hope to see you next month, because next month's topic is on spinal fusions, both from the CPT perspective as well as on PCS coding on those fusions. So thank you again. Have a great day, and we hope to see you next month. Bye-bye.